Thank you for joining today's NCCN webinar for patients chronic lymphocytic leukemia, or CLL, and small lymphocytic lymphoma, or SLL. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines from patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Larry Kripe. Dr. Kripe is Professor of Medicine at Indiana University Melvin and Bren Simon Comprehensive Cancer Network Center. Following Dr. Kripe, we will hear from Stacy Dye. Stacy is a nurse navigator for Indiana University Health Simon Cancer Center. And our third presenter today is Andrew Shore, patient advocate from Web Savvy Health Consultants, LLC. And now I will turn it over to Dr. Kripe.
Thank you, Tanya. Thank you, Mark. Good afternoon, everybody. My remarks today are designed to help you navigate CLL/SLL. I think we all deal with a lot of information and trying to decide what information is most relevant and useful is quite difficult. So this is my attempt to just give you a feel for what I would think would be useful or the kind of questions that come up in my practice and when I'm taking care of people. As Tanya mentioned and Mark mentioned, you'll have a chance to ask any questions. And I'll say my ultimate goal is to leave you with questions, not necessarily to send to me, but to next time you meet with your doctor, to perhaps there are things you would discover during these comments that you would like to discuss with him or her. All right, so I'm going to focus on several key topics. Immunophenotype, meaning how did we establish the diagnosis, a concept called progression, prognostic factors, risk stratification, how all this comes together when we think about what options there are and their benefits, harms, and burdens, and then how you might approach treatment decisions with your oncologist. So let me explain immunophenotype in the diagnosis. So immunophenotype is basically our way by a test called flow cytometry to figure out what the cells are by what they're expressing on their surface. So most people with CLL will present with an incidentally discovered lymphocytosis. And the first question is it clonal, which we can demonstrate by flow cytometry? And then after that, there are three potential diagnoses. CLL, and I'm not going to give you the full immunophenotype, but basically you should know that there are certain features we see by flow cytometry that are pretty unequivocally associated with CLL. You should also expect, if you're early on in this journey, that sometimes, even though there is a clonal B lymphocytosis, it turns out not to be CLL, it's other diseases, for example, mantle cell lymphoma, or even sometimes we can't quite tell what it is. A very closely related test is called FISH, which is a way for us to look at not the cell surface proteins, but to look at the chromosomes of the cells. One thing to understand, I think, is that FISH is never diagnostic of CLL, although in cases that are equivocal, there may be diagnostic findings that would lead us away from that diagnosis. So this basically would be how the immunophenotype of CLL is discovered. It's a little more, so then once you have that, I want to, before we talk about the various diagnoses under the immunophenotype, is just spend a few moments talking about progression, because that will figure in the next slide. So basically, progression is any undesirable change in medicine. Examples of progression that we'll talk about would be a monoclonal B lymphocytosis to CLL, low-risk CLL to high-risk CLL, which means there's a transition from observation to treatment. Another place this comes up is one of the main endpoints we use in developing drugs is something called progression-free survival, which is just the observed interval between evidence of treatment response and evidence of loss of that response. I'll just make one quick point is that progression is not transformation. Transformation is a much different situation. Okay, so let's go through what happens to people who have an elevated lymphocyte count. The criterion is that the cell count needs to be greater than 5,000 cells per microliter. So there are a fairly large number of individuals who have the immunophenotype we talked about earlier of CLL, but they don't have greater than 5,000 cells, and they don't have the lymphadenopathy, splenomegaly, or cytopenias. It's important to distinguish this because, as we'll talk about in a little bit, most individuals with this entity do not progress on to disease that needs treatment. Some do, however, maybe 2 to 3% per year. And those individuals progress when they develop more than 5,000 of these cells per microliter of blood. But if they still have no other findings of the disease or complications, they actually would consider to have low-risk chronic lymphocytic leukemia. Some of those individuals will live their natural life expectancy out without ever progressing, but more will progress to high-risk CLL or CLL for which we offer treatment currently. So that's the world of this immunophenotype. So then once a diagnosis is established through immunophenotype, and often making sure to exclude other diagnoses through FISH, we want to talk about prognostication and risk stratification. So what are those? So first of all, prognostication is simply just trying to foretell what might happen in the future, and then make a prediction about how likely that is. We then assign patients to different levels of risk for experiencing a certain event, because that helps us decide whether to counsel them for observation or to counsel them that treatment is indicated. I think one thing as you think about this, I think it's important to keep in mind that events are descriptions. So what might happen to me is one thing. And then risk is really a more statistical type expression of where we either talk about the number of people who have or have not experienced that outcome in a certain time, or you'll hear about something called the median, and that's the time by which half the population have experienced the event. So all patients are at risk for certain events, but the risk will vary by other features. And those features are what would be called prognostic factors. So here are some prognostic factors. Certainly symptoms can sometimes give us a clue. As you'll see in a moment, lymphadenopathy or splenomegaly that your doctor can feel. We do not routinely recommend CAT scans. The routine complete blood count is very important, the information it provides. And then other tests that may or may not be done at diagnosis, including serum beta-2 microglobulin, heavy chain variable region mutations, FISH, or looking for p53 abnormalities. I want to emphasize that I think this warrants a discussion with your physician or with your nurse coordinator about whether these tests are warranted. I'm not at all saying they should always be done. All right. So you can get a pretty good idea of what's likely to happen with people just by routinely available information on the exam and on the blood count. So the RI classification is 5 stages. You can see that if you're low, the only thing that happens is that you have the high lymphocyte count. Intermediate is the enlarged count, elevated count, and either lymph nodes or splenomegaly. And then the high risk are either hemoglobin less than 10 grams percent or platelets less than 100,000. People with low risk, we typically recommend observation. People with high risk, we recommend treatment. People with intermediate risk may be the group for whom prognostic factors would be of greater importance. If you choose to request, or if your doctor recommends getting the additional laboratory studies, this is how they would be used. So these basically were determined in empirical studies to be predictive. And you can see that looking for either something called a 17p on FISH or an actual mutation, the serum beta 2 microglobulin. I apologize, there's a typo in that. Mutated or unmutated heavy chain, the rise stage, and the age. And basically, we just assign the number of points to, and we come up with scores, as you can see here. You can see that most people have low or intermediate risk disease. Very few people have very high risk disease. But, and I won't go through each number, you can, if you glance down the 4th column, you can see the risk group is pretty predictive of the likelihood of being alive at 5 or 10 years, and just emphasizes the importance of why treatment is often determined based upon the risk stratification. All right. Well, the IPI for CLL was developed for people who required treatment, but there's also the people with monoclonal B lymphocytosis or rise stage 0 CLL. And this is a recent publication and I think is helpful. So once again, I'm not going to go through the numbers with you in detail. And let me say that unfortunately, the slide you have, the numbers in this part of the table are not updated. But here's the flavor for this. So first of all, you can see that people with monoclonal B lymphocytosis, many of them will go for a number of years without needing treatment. In fact, the majority don't need treatment within 10 years, and the overall survival is quite favorable. I should point out this is not adjusted for other diseases that might cause mortal events. And similarly to just being alive, so this is time to first treatment. There's a period of time that people go. Very few people with low risk disease need treatment even at 10 years. And most people are alive and well at 10 years as well. For rise stage 0, the main point is if you do a comparison, is that the likelihood of needing treatment is higher, but the survival is still as favorable between the two groups, implying, which is one of the things we'll talk about soon, that there's been a fair number of treatment advances for CLL, and many people can live a good period of time after needing treatment. All right. So what are the indications for treatment? So I think I always talk to people what are absolute, meaning that if you went anywhere, you would hear these, and then more that are relative. So the hemoglobin below 10 to 11 grams percent, the platelet count of 100,000 or less, the absolute neutrophil count, and then making sure these are not due to autoimmune diseases. There are some relatives, so some colleagues of mine will use the absolute lymphocyte count greater than 200,000, 150,000. Some people use doubling time. I'll just point out that's not my practice, just to make sure I emphasize these are relative. And then certain symptoms that can't be explained, lymphadenopathy or splenomegaly that's burdensome, or autoimmune hemolytic anemia or thrombocytopenia that doesn't respond to simple treatment. If you're on support groups, you'll know that people are very interested in looking at whether we should treat people with high-risk CLL up front, and those are actively being investigated now. First-line treatment options are listed. These 3 drugs are what are called Bruton tyrosine kinase inhibitors. There's currently only one BCL2 inhibitor, and they may or may not be given with an anti-CD20 antibody. Intravenous chemotherapy is occasionally thought about, and also there's a great deal of excitement about potential combinations of therapy. But for the most part, I'm going to stick with the upper 4, because I think that's for most people where their treatments are going to lie. All right. So this is a slide that the group wanted to ask the question, does the IPI still work in the era of targeted therapy? But I'm going to use their data for slightly different reasons. And that's to show that if you compare chemotherapy or chemotherapy with monoclonal antibody with targeted therapy for any group that's needed treatment, you can see the likelihood of progression-free survival at 3 years or overall survival is better than using chemotherapy or chemoimmunotherapy. And that's why, as a rule, I think, once again, we would say that there's very little indication for using chemotherapy in first-line treatment decisions at this point. So how do you choose your better option? So what I didn't show you, but I'm just going to tell you, is that the progression-free survivals look pretty similar for the 4 drugs I talked to you about. So your best decisions are by the best available evidence, which range from professional experience to randomized phase 3 trials, and your values and goals. Because I can't tell you what's more important to you, and I really need you, and your doctor needs you to help figure that out. So basically, I focus a lot on the benefits, harms, and burdens. When I talk about them, I try to distinguish between information that I think would inform a person's choice versus managing what happens. So for example, nausea is about the same across all these agents. So I don't think you would use that to make a choice. But once you've made your choice, Stacy and I would want to talk about how we're going to manage the choice you made. I'm a big believer that often it may be easier to just say, here's what I recommend and why I recommend that. And then you can evaluate how well that makes sense given what's important to you. So you don't have to say to the doctor, you decide. You can say, what would you recommend and why? And then that will give you really a great snapshot into the information you might want to use to make the decision. So let me sort of explain how that might work. So we talked about the benefits. So if you look at this, the overall response rate and the progression-free survivals are pretty similar between the 2 types of drugs. The complete remission rate is different. So you may be working with a doctor who values this, and that would be explained to you, and you can decide whether you value that. The survival estimates, once again, are pretty similar between the drugs. So you wouldn't make a distinction between the drugs based upon that benefit. The point of this slide would be to just illustrate to you why it might be helpful to say, what are the benefits that you use to make a choice between those agents that you're considering? Now, the potential harms are different. So atrial fibrillation is associated with the BTKI drugs, bleeding, infection may be slightly higher. So if atrial fibrillation is something a person already has, most likely this class of drugs would not be valuable. On the other hand, tumor lysis is seen with venetoclax and not seen essentially with BTKI therapy. And I do think it's very helpful, even if you may not know from an expert standpoint what these are. So I was recently explaining to a person I care for that venetoclax has tumor lysis, and that occasion that leads to kidney injury. And that stopped the conversation because they had an uncle who had kidney failure, and that was very unpleasant to them. And so they said, I would not do anything that would put my kidneys at risk. So that's how your personal values and goals can play into this. And then there's potential burdens of treatment, which in the interest of time, I'm not going to go through. But I think they're not necessarily harms or benefits, but they're relevant to how you're going to live your life on treatment. So at that, I'm going to progress to, so you can listen to one of the most amazing nurses that I've ever worked with. Okay.
Thank you, Larry. Hi, my name is Stacy Dye. I'm a nurse navigator here at the Cancer Center. I have worked with Larry now for 12 years, so we have been together for a long time. I'm going to just discuss first the role of the nurse navigator. So what I personally do is I meet with all patients in clinic, give them my contact information. I try to go into every room with the physician. I really want to be involved in the conversation so I know exactly what's going on and what the plan is moving forward. I coordinate all care. So this could be next appointments, infusions, labs. A lot of our patients get labs elsewhere. So I help to facilitate that with other university hospitals. I educate patients and families. So this could be a range from what to expect with admissions, medications, medication changes, any kind of schedules, infusions, a lot of lab results. We go over things like that a lot. I am an access point for everyone, so I'm available to patients. I make sure they know how to contact me. They have my email. They can get a hold of me through the portal. We have an IU Health portal. A lot of facilities have a portal that you can contact through. And of course, they have my phone number and they know who to contact on holidays, weekends, or evening hours. I triage all the Cerner messages. So Cerner is our portal. So it's a lot easier for us to get portal messages on patients. So if you have access to that at your facility, it's easier for us because we can forward it on to the physician and get you an answer quickly. We send pre-certifications for all treatment or admissions, and our pre-certification department helps us do that. Coordinate with outside physicians. Like I said, a lot of our patients have local doctors, so I'm in contact with their nurses, and we try to coordinate care so it's easier for patients to not have to come here if they live far away. I send referrals as needed. So this could be to our pharmacy, dietary, social work, etc. A lot of my patients have questions after they have a long conversation with the doctor. So I do talk to patients a lot about, I reiterate what the physician has said. So I get a lot of calls from patients that they have a question about something, they didn't understand something, the family member maybe has questions, they forgot to ask something, or they need clarification. So I do talk to patients a lot about that. I am your advocate here, or your nurse is your advocate. Our goal is to support you and give you any of the guidance that you need. If I don't know the answer, I find someone who does. And like I said, I will get back. I try to get back to my patients immediately with those answers. So when to call your nurse. Anytime you have a question or a concern, there's never a wrong question. I have people say that they don't want to call me because they feel like they're bothering me. You are not a bother. I would rather be called sooner than later. So calling your nurse at 2 o'clock on a Friday afternoon sometimes does not get your answer that you need, going into a weekend. So please call sooner than later because we'd rather you call us than not. If you have a symptom that you need addressed or you have a question about, please call. I have, like I said, a lot of patients that call and they feel bad because they feel like they're calling me too much. That's never the case. We'd rather hear from you than not hear from you. Once again, if you or your family member has any questions about something that you talked to the physician about, I can reiterate that for you, or I can find an easier way to discuss it. Family members a lot of times have questions, they weren't here, and the patient, is trying to explain to them in a different way than what maybe they've heard from the physician, and, call me and I can help facilitate that. A big question is whether or not people should go to the ER. Depending on the symptom, we try to triage these over the phone. We really don't want to send you to the ER if we can help it. So we can try to save you that visit if you call first before going in. Okay. Members of our care team. So I work, I could not do my job without social workers. We have social workers that work with us directly in our clinic. They can come in and see patients while they're here. They have numerous resources that they are privy to that a lot of the nurses don't even know about. So like I said, I couldn't do my job without our social workers. They're always available. And if they can't see you in the clinic, they can call and they can talk to you over the phone. We have oncology pharmacists. We always have a pharmacist that sits in our clinic with us. A lot of these oral chemotherapy medications, they're expensive, and our pharmacists go in and speak to the patients and help with the medication requests, for assistance for financial aid from the medication. And they go over all the new drugs with the patients, which is fantastic for us. Our infusion nurses, they're basically an extension of me in the infusion area. So I'll talk to the patients about their infusions. They'll go to the infusion. The infusion nurses will then reiterate what I've said. They can help answer any questions. They can contact me or the physician once the patient gets down there, because 9 times out of 10, questions come up once they get down to the infusion after they have seen us in the clinic. Here at the Cancer Center, we have something called the Same Day Clinic. It's basically an urgent care of sorts, but it's only for our patients, and they can be seen the same day. So patients can contact me if we have an issue that we don't really need to send them to the ER for. We can have them come in and see one of our nurse practitioners here in the Same Day Clinic. And like I said, that can save an ER visit. And then they're here at our facility also. And a lot of times the physician's here and they can run down and see them if needed. The pre-certification department, these are the behind the scenes folks that get all my messages about pre-certifying infusions or chemotherapy or different injections. And they contact insurance. They get everything approved ahead of time. So they do all that behind the scenes. We have dietitians here. Many of our patients have appetite changes or taste changes with their treatments. So we have dietitians that are available to help figure out, a good diet for them, or different like drinks like Ensure and things. They can get a lot of that for free for our patients. So they're a great resource to have. And then lastly, our case managers. Case managers are more of an inpatient when our patients are discharged, but they do work closely with our outpatient social workers and help facilitate things for patients, once they're discharged from the hospital.
Okay, thank you, Stacy. I'm Andrew Shoreham in San Diego. I've been living with CLL for 28 years, and I'd say I've seen it all. And I've had the privilege of interviewing scores of CLL providers. Stacy and Dr. Kripe, you are very devoted, and I hope everybody can get the quality of care that you provide. Let me tell you a little bit about me. So I was diagnosed at age 45. I was living in Seattle at the time, and I had 2 of those 3 kids there. That's my wife in the middle, Esther, 39 years now. And I was getting nosebleeds, and I went to the just local clinic to my primary care doctor. And based on a blood test and then a repeat blood test, I had exactly what Dr. Kripe was talking about, and that was elevated lymphocytes. And the primary care doctor said, have you had the flu? Have you had an infection? No, no, no. And finally I said, well, what does that mean? And he said, well, it could be a leukemia. And for so many of you with us today, you've been told that and you're terrified. And I was. And I had no idea of differences between acute leukemia and chronic leukemia, or the different types of leukemia. Dr. Kripe mentioned mantle cell, or there's hairy cell, or there's all these different types, CML. It's all leukemia, and it sounded deadly to me, and I had little kids. So what happened? In the early days of the internet, there was what we call a listserv, and there were actually people with blood cancers who were on there talking to one another. And so a neighbor of mine helped me connect on the computer that very first night, and I found out I wasn't alone, and that there was this condition, CLL, which sounded like what I had. And I connected with a woman who was a leader of one of these groups who'd had CLL for many years, really one of the great ladies going back about 3 decades in CLL, a woman named Barbara Lackritz from outside St. Louis. Some of the people who've been around a while may remember her. Anyway, she explained that I should chill out, which is exactly what I say to people today. And it's even a more powerful statement because, as Dr. Kripe said, there are numerous treatments to help all of us live well and hopefully live long. Less so then, but still, she said, CLL typically doesn't move fast, but it is important to connect with a specialist. So I did. Now, Dr. Kripe is a specialist at Indiana University, and there's a group around the country, most of them associated with the National Comprehensive Cancer Network, that's putting on this event. I get to sit with them or be on with these experts a couple of times a year, experts, just tremendous experts who set the guidelines for recommended treatment. And one of them was a guy named Michael Keating at MD Anderson, who devoted his life to CLL. And so he became my doctor. I had an HMO doctor in Seattle, but then we deferred to Dr. Keating for sort of a treatment plan. And part of the treatment plan was no treatment for more than 4 years. And that can be exactly what Dr. Kripe was describing based on the stage of your illness. I felt pretty good. I had higher lymphocytes, and they were going higher. And we watched that sort of doubling time that he mentioned. But other than that, I felt pretty good. I was a runner. I continued my life. And so what happened? After 4 years, I was in a clinical trial that may have benefited some of you. It was a phase 2 trial. So it's sort of an intermediate trial for chemoimmunotherapy. What Dr. Kripe said has really fallen out of favor in most places around the world. It was drugs called fludarabine, cyclophosphamide, and rituximab, a CD20 targeted monoclonal antibody. And guess what? It worked. And it led to a 17-year remission for which I was very grateful. But as can happen, and has happened to many of the people who received FCR, we needed something more at some point. And so I was retreated in 2017. And fortunately, that's worked. Now, what CLL treatment do I get now? I get immunoglobulins, so that's IVIG, intravenous immunoglobulin. Some CLL patients will get that. Why? Because our immunoglobulins that help fight infections are low. But again, that's a very personal discussion between you and your doctor, should you need that. I didn't need it for many years. Now I get it monthly. And does it help me avoid the infection risk of CLL? It appears like it does. And then the other issue is just really getting vaccinations. And so just the other day, I got an updated COVID vaccination. Now, I will mention that I hope to inspire you and give you hope today, but do I know people who've succumbed to CLL along the way? Yes, I have. Do I know some that succumbed with CLL during COVID? Yes, I do. And so I think it's very important to have a discussion with your doctor about being up to date on your vaccinations and considering your travel risk, when to wear a mask, etc. Those are very real issues now. Okay, let's go on. So what have I learned on this 28-year journey? Well, first of all, you're not alone. So I've met literally thousands of people with CLL, and most of them are doing well. Do we all worry? Yes. Do our families worry? Yes. But can we go on with our lives? Yes. And that's really my key message to you. It's a chronic cancer. I was interviewing my doctor recently, Dr. Tom Kipps here in San Diego, and I said, well, if it's chronic, why don't you just stop the research? And they said, no, we want to cure it. So there are people in labs around the world still working for a cure. But right now, it's a chronic condition for most people where it can be well managed. So basically, you don't have to freak out. You're going to get regular blood tests. The numbers may vary, but typically your doctor will show how they're pretty uniform. And that's been the case for me. And then there are many options to live well and live long, and they're increasing. They're more in the lab. They're more in late stage trials. And I would just put a pitch in for being in clinical trials. I was in a phase 2 trial and it worked for a long time. So I'm very grateful. And then stay informed and be a partner, like with people like Stacy and Dr. Kripe, in your care. Now, it may be that the clinic you go to doesn't have all the resources that Indiana University does, or where I go, UC San Diego. So seek out those resources. Some may be online. Some may be occasionally going to an academic medical center. Fortunately, more of the community physicians are knowledgeable about CLL now, but you can always ask questions. And then the last thing I'd say is pay it forward. You know, speak up. If you're doing well, tell other people about it. Educate them about CLL. Help them understand that there are options, that they're experts, that they're devoted providers like Dr. Kripe and Stacy. And then I would say things to remember, and that is it varies by patient. If you go on Facebook and somebody says, oh my God, and they show pictures of, infection from mosquito bites and stuff like that, well, that may not be you. That may be them, but it may not be you. Or they may be getting treatment X, but that may not be right for you with condition Y. So another patient's story may not be your story. And just a couple more things. CLL is a journey, and it's an increasingly positive one, and I hope you get that. It really is for most people. And have a provider team that you trust. So if it's not Dr. Kripe and Stacy, have people who are in the know who can be part of your team. If they're not right where you are, have your local hematologist consult with them, and you can be the bridge for that. And remember that you can go on and live your life. My wife and I travel a lot, and we are mindful about it, mindful about our risks. Where can we get care? Where is it safe to travel? COVID shots, etc. But live your life. And then just some resources I'll mention. The NCCN patient resources, the patient guide will define many of the terms that Dr. Kripe mentioned: cytopenia, lymphocytosis. If there's some things you didn't quite get, they're all defined in the NCCN patient guidelines, okay? The Leukemia and Lymphoma Society is a wonderful organization. They have people you can call. The CLL Society and my friend, Dr. Brian Kaufman, wonderful resources and events around the country. Patient Power, which my wife and I co-founded, has loads on CLL. And then there are many programs on YouTube on something called The Patient Story. Thank you so much. We look forward to your questions, but it's a very great time of hope in CLL.
All right, so there are a few questions coming in. I know it takes a little time. So I'm just kind of reading through this first question for symptoms. Okay. So this first one begins with someone who was diagnosed in 2016. Stage 0, not in remission, symptomatic, night sweats, no weight loss, feeling sick and tired. So let's see. I'm just waiting for the question. So I think the question is, I think, and it's something that everyone, all the presenters has discussed, is like, well, when do I start treatment? Like if I'm tired or I don't feel well, is that enough to start treatment? So maybe we'll start there.
So that's an awesome question. I assume, Tanya, I was okay to go, but
Yes,
that's
sorry,
an
Larry.
awesome question. So I would say a couple things. One is there's a spectrum of symptoms that I have varying levels of confidence that I might be able to help somebody by treatment. So unexplained fevers, unexplained weight loss with an excellent appetite are usually symptoms that are pretty reliable. On the other hand, fatigue, tiredness are usually symptoms in my experience that do not get better. And so I'm always reluctant to offer treatment based upon that. So the take-home point would be talk with your doctor about what symptoms, prioritize the symptoms that you're having in terms of wanting to get rid of them. Secondly, I would say that there's a tendency when people have a disease like CLL for everybody to attribute whatever's happening to them to the CLL. So I think you need to maintain in mind that you, in fact, may have the symptoms, but they may not be due to the CLL, and the CLL will not help you. The third and final point is there's no doubt we pay less attention to people's symptoms than we should as a rule. So if your symptoms are really the big thing that you're struggling with, do your doctor a favor and either talk to the nurse before or come in with a piece of paper and say, this is what I really want to talk about. I don't feel well. I don't necessarily want to talk about my counts or new treatments, but I want to talk about how I feel and what we might be able to do about that.
Thanks, Larry. I really like that. I think that is helpful, like you said, to come in with the piece of paper and, to outline how you're not feeling well, to give everyone advance warning that this is what you want to discuss. And then, like you said, just determining what's the difference between what might be CLL and what might be something else. So we do have other questions like, why is fatigue so common in early CLL? Or is it common, I guess, would be the follow-up question, Dr. Cripe.
I'd like Andrew's and Stacy's perspective on that as well. Fatigue for me is very complicated because I often am sitting with someone who says, I'm tired, and then you listen to what their average day is like, and I think, oh my God, who wouldn't be tired with that day? Their parents, they're working, they're older parents. So I think fatigue is one of those symptoms that we often try to ignore because there's so little we can do for it. But I think taking a step back and ask yourself, how does the fatigue manifest? How does it interfere with my life? Does it interfere with my life? But I really say to the people I care for, I don't want to make a treatment decision based upon fatigue and fatigue alone.
Maybe I could make a couple of comments. So fatigue for me, and someone once said this to me, so it's not sleepiness, it's where you're just bone tired, or I used to be a runner and I knew I couldn't run as far or as fast. I just didn't have the energy, and I still deal with that. So that's very real to me. What triggered my treatment in after 4 years was my lymphocyte count was going up, and I was developing swollen lymph nodes. And Larry, you might comment on lymph nodes as well. So different places in the body, they could feel the lymph nodes. I was tired or fatigued, and I can't remember if my spleen was slightly enlarged, but when I had treatment, my lymphocyte count, my overall white count had gotten to be 253,000, and mostly immature lymphocytes. So it seemed to be an indication of treatment. And as I mentioned about the phase 2 trial, there was something they thought might work. So, and now we have those treatments. So is there an argument for treatment that could bring the white count down? You'd feel better, shrink the lymph nodes, et cetera. And it all worked for me.
Stacy?
From the fatigue standpoint, I would say the same thing. I feel like patients call and they say, I'm really tired, and they want to attribute it to the CLL. But then when they start telling me all the things that they've done, or, they have little kids or whatever it may be, and then we just talk it through. And normally it's just that it's their normal life, and they're usually tired, but they're trying to pinpoint everything back to the CLL, and it might not really be that's what it is.
Great, thank you all. I think, like you said, it's helpful to communicate with your care team for sure. So Stacy, I guess this would be for you. What are the risks of the IVIG infusions?
I don't think there are many risks to it. Do you, Larry?
Oh, yeah. So um, the risks are small, but I would say the following is that I think it's very important, as Andrew said, it's a personalized decision. It's pretty clear that an isolated low level of immunoglobulins is not a sufficient reason to receive replacement. I think in the risks of it, though, because there's very little benefit in that situation. In the risk category, we tell people that one, there's an infusion reaction risk. Two, it is a human-derived plasma product that every once in a while, certainly not more, every decade or so, there may be a rare virus that's transmitted. And I think the other risk, which is not quite a risk, but it's a burden, the monthly infusions, needing to make time for that might be a burden. So I would say avoid trying to do it based upon numbers. And if you do it based upon a symptom, keep a diary about what's happening to that symptom. And if after several months it's not better, it's worthwhile reconsidering whether IVIG makes sense.
Yeah, I was going to make one comment because I've been getting it for a number of years now. I know all the nurses in the infusion center, and we joke about which vein we're going to pick. I mean, you could have some kind of port or something, but short of that, I get poked, once a month. I don't really enjoy that. So, but in my case, the doctor and I agree it's probably limiting my risk of an infection. Okay. So I have to sit there for 3 hours. But I haven't, like Stacy said, I haven't had a problem with it. So I think it's been good for me, whether it's needed for you, whether you want to spend the time, whether you want to get poked regularly. All those are questions to discuss with your team.
Great, thank you. This question is CIDP common with CLL, and what are the symptoms?
Um, I think I know, can the questioner spell out what I want to make sure I understand what they're asking about.
Okay.
Sorry.
I'll just say,
I mean, I'm pretty sure I know.
okay.
I don't want to assume. Let me-
All right, we'll wait and we'll see if we can get information on that. So after chemotherapy, side effect of bone pain, numbness, and tingling nerve pain, does it end? So Stacy, maybe you
Oh.
want to take that. Oh, go ahead.
I was just going to say, I mean, I had chemo as that chemo immunotherapy. And what I had were low neutrophils for a long time. And I would get every cold I got sinus infections and needed antibiotics. And Larry, you may want to, or Stacy, you may even want to comment about the use of antibiotics for CLL patients versus the general population. But I didn't have any nerve pain or anything like that.
I was gonna say, I feel like it's more patients that call with like the bone or the deep aching pain that tends to go away. But then if it's the neuropathy, which is the tingling, I mean, that could stay around for quite some time. Wouldn't you agree, Larry?
Yeah, so I think what I would say harkens back to a point I tried to make earlier. I think it's very important to because once we're in all of us, when we're in the exam room, there's a certain pressure, it's just a different dynamic. So if you can think about and prioritize what symptoms you're experiencing, I think you'll be better off. The second thing I'll say is that there's no doubt that as an oncologist, I sometimes forget that people who successfully go through treatment carry longer term complications. And the people I appreciate the most are those who knock me on the side of the head and say, pay attention to me, stop just looking at my normal CBC. Your oncologist or your oncology nurse or pharmacist, they all want to help you. Sometimes, unfortunately, you have to fight a little bit for our attention and say, this is really my number one priority. But there are lingering effects and that you'd want to. So for neuropathy, it may be that it's not related to the treatment itself, and a visit with a neurologist will uncover a different etiology.
Okay, thank you. So this question is around vaccinations from a 73-year-old male with CLL. So the question is about an efficacy of flu, COVID, and other vaccines in warding off infections, and that his PCP and hematologist both encourage him to keep up to date on his vaccinations, but also caution that they might not be as effective as they would be with someone who doesn't have CLL. And so this seems a little counterintuitive, especially if my white blood cell count is normal or high. And so could you discuss in more detail the effects of CLL on our ability to fight infections? And is there anything we can or should do to help the body?
Thank you for that question. So the lymphocytes represent hundreds of thousands of different cells that are capable of responding in a very particular way to some element of an invading organism, or a virus, and let's just use a virus. What happens in CLL is that actually fairly early on, is for some reason, often the normal immune cells become less reactive. And so they're less capable of mounting a productive response for the person. And that's just the biology of the disease. It's actually exciting because some recent treatments, there is now evidence that there may be so effective that normal immune reconstitution happens. So that's one thing. So your doctors are correct, but I would say this. we don't know for any one individual whether a vaccine is ever effective. There's no laboratory test to tell us whether an immune response to a vaccine is going to be protective. On the other hand, we know that people with CLL who get the flu, who get COVID, tend not to do as well. And so I would say I would ignore the concerns about whether or not you're going to respond to it. And I would encourage you to stay up to date on your vaccines and then adjust based upon your risk tolerance, what you're going to expose yourself to. So I agree with people that COVID vaccines may not be as effective for people like you, in which case you probably should be more likely to wear a mask in crowds. But I don't think it's to the point where you could say, therefore, or you should say, therefore, I'm not getting the vaccine. I think Andrew can speak to this personally, but early on in the COVID pandemic, it was horrible what we saw. It surprised everybody, but it was horrible.
Yeah, I mean, I know two people, prominent people who with CLL who passed away from COVID. And we were all really terrified, and so very extremely cautious. I have been saying, live your life. So we travel smartly. I got my COVID booster just the other day. No side effects. Now, did that mean I had a lower immune response? I don't know, but it didn't make me, I don't even have a sore arm or anything now. So, but I feel like it was the right thing to do. So I would recommend it for people. I mean, it can't hurt. And I think knowing the toll that COVID took on some of the people in the CLL community, I think it's wise.
Thank you. So this one's about hives as a symptom of CLL. That someone had hives and they went to their GP and was diagnosed with CLL, received treatment in 2014, and recently the hives came back. Immediately thereafter, my white blood cell count tripled, and my doctor stopped me from taking ibrutinib and started Gazavia and venetoclax. The hives disappeared after 2 months of treatment. So I'm not sure what the question is. I guess are hives a symptom of CLL?
Yes. I would say there are people with CLL who seem to have exuberant reactions to things like bug bites, poison ivy. And there are individuals whose primary manifestation is spontaneous hives. So I think it's well documented. Certainly the dermatologists recognize that. And I think that it makes a lot of sense that if the disease is in remission, that manifestation may be less noticeable. The other way to approach it is not to treat the disease itself if there's not other indications for treatment, but to use antihistamines, or the dermatologists now have a monoclonal antibody that they can use for severe hives.
Okay, thank you.
Tanya, I just wanted to make a
Yeah.
pitch for dermatology for CLL patients.
Sure.
So, and Larry, you may comment on this. My understanding is that CLL patients are at a bit higher risk of skin cancers, and I've had Mohs surgery on my nose and some others. And I'm in California, Southern California, so I'm always wearing sunscreen, but I always get a yearly skin check with a dermatologist. And in interviewing some dermatologists, it seems like that would be wise for a CLL patient to have a relationship with a dermatologist. But I'd love to hear what the team says about that.
I agree that people with CLL have an increased risk of skin cancer. So I think that's definitely true. I would think that at least one, but what I don't know, and I just want to be clear, I don't know this. I think a visit with one to see, have an assessment about what are your risks for skin cancer. But the people I take care of with CLL who have had skin cancers, I do make sure they remain plugged in with the dermatologist.
Thank you. What does it mean when flow cytometry results differ from tissue sample versus blood? Example, lymph tissue sample from neck biopsy diagnosed SLL, CLL, but blood work was unremarkable.
So that's a couple different things, possible explanations. One is, in fact, what you have is SLL, which by definition should not have more than 5,000 lymphocytes with a CLL, SLL phenotype. So it may be that, especially if the disease were at its first presentation, it may be truly that there's no evidence of the disease in the blood. Typically, we would not do flow cytometry of the blood in someone with a lymph node that showed SLL unless the lymphocyte count were high. And even then, you might not need to do that. So I think it's probably that this is truly SLL at this point, and that time will show whether it stays true to that. The other thing, which doesn't quite fit this situation, but these discrepancies are good to ask about, it may be a technical factor, and that there was just something that happened with either the FNA or the blood sample that it wasn't really that accurate. So the first thing I would do is just say, well, was it accurate? Were there enough cells isolated, and did the controls behave themselves?
Okay, thank you. So at age 37, 11q deletion, no symptoms, caught by a biopsy of lump on neck, CLL, SLL in lump, blood clean, all numbers good. Is there any science in diets to keep the spread from going to the blood or at least prolong? So they're talking about, yeah, how to, I guess, delay treatment or what steps you can take, or if there are any.
I think there's nothing that's ever caught my attention to the point that I would at all recommend it. I do want to clarify one thing about, I think is important for SLL/CLL, is the lymphocytes are different in that they normally go between the bone marrow, spleen, lymph nodes, and blood. So spreading is not really so we're not going to stop spreading because they're there as part of their natural behavior. Some ideas that what I say to people who ask me about alternative medical approaches is I'd say, well, be careful how you spend your money and be careful how stringent you have to change your life. Because there are certainly suggestions out there that you can spend your money on immune boosters or you can go to a meatless, sugarless diet. But I think the science behind that is very sparse. Stacy, do you?
No, I was going to say, yeah, please call us before or call your provider or your nurse before you want to start something new, because I've had patients call that have found the next best thing to slow, the growth or whatever it may be. And they're spending a lot of money on these supplements or herbs or things like that, normally it's not something that we would recommend taking.
Right, and some herbs and supplements can actually counter or interact with the targeted therapies. They don't play nice together.
Yes,
and
we
I
also say that.
I would say
Again,
sorry, go ahead. No, I was just going to say, we always tell them to please call us before you start a new supplement or an herb or something, especially if you're on a treatment, because exactly right. We want to run it past the pharmacist. It could very well have an interaction.
And don't eat grapefruit.
Equally important is we'll never be able to know whether these things have interactions because there's so many of them. So I try not to be dogmatic, but one dogma I really push is I ask people when we're actively treating the disease not to do modifications of much, because I don't want to find out that this was a 1 in a million interaction. So I'm totally supportive of it once active treatment is over, if they want to do it. But I do, because we'll never be able to study all these compounds.
Thank you. And that is a good question, because it's something that's been in my mind too. It must be very difficult if you're asymptomatic or there's, that you don't need to necessarily start treatment to wait. It must be very difficult to live with CLL and wait 4 years, 10 years for treatment and not feel like there's anything you can do, because I know a lot of people like to do things. They like to be proactive. So I guess I have a two-part question. Kind of how do you manage the waiting game? That would be a good one for Andrew. And how do you kind of counsel people, like you said, on if you want to do something, these are the things you could do, rather than perhaps, like you said, don't um, modify your dose, or don't modify things without speaking to your care team. So we'll start with you,
So,
Andrew.
Tanya, so as I said, I went 4.5 years with no treatment. The clinical teams call that watch and wait. The patient community calls that watch and worry. So really what we're talking about is how do you cope? And so my wife was totally freaked out. She tended to be an anxious person, but never took an anti-anxiety medicine. But she started as we went through counseling. So as a couple, we went through counseling to say, okay, Andrew has this chronic cancer. There's a lot of uncertainty on when treatment will happen or if I need treatment, and a smaller percentage of people don't. And, will there be another shoe that drops? And so counseling helped us a lot. The anti-anxiety medicine that Esther continues to take today, she'd be happy to discuss it with anyone, has helped her a lot as we've gone on. And there's also anxiety if you're going to have a treatment change, or if you've been in a remission and then you're out of it. And Larry could talk about that. So there are these points along the way that can be very unnerving, but they're people who can help you with it.
Yeah, Andrew, that's spot on in my experience. So Andrew had said something earlier. It's like that word leukemia. You can't say it without raising a lot of red flags. And so one of the things Stacy and I work with is to say, look, we have to call it leukemia because that's what it is. But we need to also back away from that word because there's also this word chronic. And I think it's spot on that it's about how do we cope, and everybody has different coping styles, but we all do cope. I do acknowledge up front that I know you think this is crazy that you're being told you have leukemia, but your best option is to watch and wait. I call it observe until progression. And then finally, and I know people find me a fuddy-duddy with this, but they'll say, so do I have the good kind? And I think I just would say to everybody, as I say to the people I care for, I can't imagine ever using the word leukemia and good in the same sentence. I don't know what it would be like. I don't ever want to find out personally what it would be like. But I think to acknowledge for everybody that this is a real disease, even though some people may live for years or decades without treatment, it's still a real disease and it creates real reasons to be anxious at various points.
Stacy, what would you like to add? Since you do have a lot of direct contact with warriors, I'm sure, and lots
Yes,
of
oh,
questions.
absolutely. And coping, that's exactly what it is coping. And so we do have quite a few patients that our social workers help set up with counselors in their area. That seems to help quite a bit. And not just for patients per se, but their family members, like Andrew said. And the other thing that I've noticed with patients is at the beginning, when they're first diagnosed, obviously they're overwhelmed, right? And so, you know, we check their blood counts periodically. And then once they see that the blood counts aren't moving in a quick way, then it helps them alleviate some of that anxiety and then feel a little more normal and live their life a little normal. That's what people have said to us before. So I feel like the patients, when they're first diagnosed, have this, they're very overwhelmed, and then they're waiting for the blood counts to get worse. But as we're checking the blood counts and they're maybe not moving as fast as the patient thinks that they will, that helps to alleviate some of that anxiety also. Then they really know that it's a long term and it's not something that's happening in a short period of time.
I would just add one thing that people do say to me, which really breaks my heart because I worry that they think we're not taking it seriously. They'll say, well, at least I don't have something as bad as, and then they'll just say, or they'll talk about the waiting room. I would just say once again, this is a serious disease and you should feel your team recognizes how serious this is. Nobody wants this disease, no matter how good the treatments are. Thank you.
Thank you. So thank you, everyone. We are out of time for today. Thank you for attending. Thank you for all the questions and the comments in the Q&A box. We appreciate that, and we're sorry if we didn't get to every single one. The NCCN Foundation would also like to thank our corporate supporters of this webinar. Thank you all again.